lo staff del Promis ha deciso di spezzettare l'incontro in diversi webinar, quindi oggi è di fatto il primo dei nostri incontri. Per oggi lascerei subito la parola al relatore che si occuperà di presentare il MAFEIP e ci guiderà in un esempio concreto, in quello che è un esempio concreto dell'utilizzo di questo tool. Come detto, vi pregherei di tenere i video spenti e in muto, così da permettere una migliore connessione e lasciare che il relatore riesca a svolgere una presentazione più fluida. So that Francisco, if you're still there, the floor is yours. Thank you very much, everyone.
Okay. Thank you. Thank you. Can you hear me?
Yes, very well.
Okay, perfect.
Okay.
So, first of all, thank you very much for the invitation and for hosting the seminar online and despite the current conditions. Second, let me thank you very much. You are all working on the health system, and I'm calling you from Spain. So we know how is the situation in Italy, and I would like to thank you very much for all your efforts to keep the health system working. Okay. Having said that, let's go to the presentation. Okay. I'm gonna divide the presentation in two parts. The first is related to the importance of evaluation, okay, within the innovation landscape, and the second one is gonna be a concrete examples of how to use MAFEIP, okay. So let me start by saying which is the most innovative country worldwide from the health system. I did this question in several occasions, and many times people say United States, or because they are always innovating. This is one side of the equation. Because then when we try to assess other indicators that are not related to innovation and the money spent on technology, we see that the United States does not perform, even though they invest a lot on ICT and on innovation, does not perform very well on health expenditure. Okay, is the first, spend a lot. And apparently life expectancy at birth is not great because the amount of money they spend. And the same goes for life expectancy at 65. Okay, so what these slides are telling us is that maybe innovation and spending in ICT is not enough. And that's why we need to put into the equation evaluation. So how these resources that are limited, okay, are used. Then when we go to another important minister, so I know in Italy it should be the same. In Spain, the two ministers that are dealing with the current crisis is healthcare, of course, and then economy. Okay. So when DG Grow, which is the economic minister of the European Commission, try to disentangle the role of technology in healthcare expenditure, okay, they say that technology in general affects public expenditure on healthcare, okay. And what they are saying is that we have to be careful because it's an expenditure and there are several concerns about the sustainability of the healthcare system. So technology, and ICT is a technology, is perceived as expenditure with a return, let's say, that is in many cases unknown due to the lack of evaluation. I'm going to be very quick this one, okay, is just to remember the performance of the healthcare system on the 27 OECD countries, okay? Again, we are not just talking about innovation. We cannot talk about innovation in an isolated way. We need to talk about innovation in the context of resources, health and health status of the population, and accessibility and services, okay? So we need to measure efficiency, effectiveness, and productivity. And there we will have the full picture. So innovation per se is not a name. It should be a tool to achieve something related to the health status of the population, or the services provision, so to speak, in these three axes, okay? The problem or the issue is that the ICT are not pills, are not as, quotes unquote, as simple as assessing pills, okay? There are several studies showing the difference between assessing drugs, okay, on the right column, and let's say devices. We are not talking about ICT in general terms. This is about devices, okay? From the actions we are doing for the product life cycle, how technology evolves and drugs evolve, from the clinical evaluation perspective, diversity and cost. All these elements needs to be taken into account. So evaluation should be together with innovation, but we are assessing not a drug, but we are more close to assessing devices, okay? Is innovation and scaling up enough? I don't think so. I don't think so. And the best proof of that is that regardless of the narrative about how wonderful ICT could be, the rollout of the technologies is slow, and the impact it has not been captured, okay? So there is a need to reinforce the message that the innovation is not enough. We need to assess the way we are doing things in a different way, so to speak. So we need to set up the evaluation questions. Did the program achieve the target objectives and outputs? Type 1. Can the effect be attributed solely to the program? And why and how, okay? And then we have the purpose of the evaluation, whether it's outputs accountability, outcomes accountability, so we are getting close to the health status of the population, and then through the intervention, learning how we did and how and why we did that, to take this best practice to other initiatives, okay? Then you have the analytical task, how you do that, okay? And the different tools or methods, okay? Very quick again, because I don't want to go deeper into health economics, okay? But I noticed while we are doing evaluations of applicativo, that sometimes when engineers, managers, and healthcare professionals work together, okay, this simple sketch from input, output to outcomes is not clear. And it's not clear neither what is efficiency and what is effectiveness. How we can do that? I strongly encourage people when they are doing innovation, just
per favore, chi fosse connesso in linea in ritardo, sorry Paco, sorry Francisco, spegnere microfoni e video. Grazie mille. Grazie davvero. Go ahead, Francisco.
No, it's okay. It's okay. I would love to encourage people every time they are thinking about an innovation to think in terms of this simple sketch. Okay, what are the inputs? What are the outputs? The treatments, and what are the outcomes? What I'm expecting to produce, and then try to, in a very simple terms, to understand what is the efficiency, so the input-output ratio, and what is the effectiveness, okay? If when we think about innovation, we have this in mind, then we will be able to design the intervention in a way that we can capture the impact of this innovation into the output and also the outcomes, okay? So this was just a quick introduction before I go into MAFEIP, okay? It's not a very nice name, okay? But it has become more and more popular, okay? What is this tool, okay? This tool is a decision analytic modeling tool, meaning that it supports innovators or healthcare managers or health professionals to conduct an evaluation, okay? So it intends to support evidence-based decision making. So whether we have to invest in A or B, okay, with making an informed decision, okay? It's online. You can go online and type mafeip.eu and request to be a user. And it basically estimates the health and economic outcomes of ICT-enabled social and health innovation, okay? It's based on traditional Markovian models. So we are not reinventing the wheel. We are just trying to facilitate across Europe. And I know that many people, many of the reference sites in Italy are using the tool to produce some evidence to take decisions. So it's a tool to support the decision-making process, okay? Here is what I was saying, then I will log in into the platform. The community has been growing. So we have more than 200 members, more than 63 cases, and more than 27 countries, okay? For whom is MAFEIP? Why I have to use MAFEIP again, or any other tool to assess my assessment? MAFEIP try to make your life simple because it's online and because it's has been tested, okay? If you are a health or social care provider, okay, you most likely are assessing, or you should be assessing the interventions to make decisions whether to invest or to buy specific technologies. So MAFEIP can help you to do that, okay? If you are a policymaker, you are the one saying, I pay this or that, so to speak. You can use or ask your providers to prove the cost effectiveness of their intervention by using MAFEIP. If you're a researcher doing innovation, you can use the tool also to, even in a pre-commercial assessment or in a ex ante, before running your intervention, to estimate what is the impact, the potential impact, and ex post to capture this impact. And if you're a company, we need to understand that the buyer of these technologies, in most cases, it is the healthcare provider or the health authorities, and you need to show the value, the value of your tool in terms of cost effectiveness analysis, okay? How it works, and then it's a very simple tool, okay, that captures different states. These Markovian models are based on transitions between states, okay? So for each, you run the intervention, so and you can select whether you want 4 stages or 5 stages. I put an example with this. I'm running an intervention using mobiles, okay, to follow up the health status or the adherence to medication by just taking a picture every time you take a pill. It's not a wonderful example. You will select the baseline, okay, adding in the baseline the cost and the utility, okay. Utility normally is measured in terms of quality of life. And then you will see, once you start the intervention, how the individuals move from the baseline to another stage, which is the disease impairment. So whether there are, in this transition from one stage to another, there are changes, the probability of you get better, or you don't get better, and then at the end, we're all gonna die, okay? This can be done with four stages. I start here, the probability of getting to a second stage, the probability of getting to a first stage, second stage, and then the transitions between all of these, okay? 5-stage model too. You can select the 3, the 5. Then I will go through the tool and you will understand better, okay? What is the results? The results are very simple. They will show you what is called the incremental cost effectiveness ratio, meaning in this transition stage, what is the difference in cost, okay? Whether there are more or less costs in relation to the effects, the outcomes, the utility, the quality of life of the individual, okay? With this, you will have whether your intervention is dominant, it's more expensive and worse, okay? We know that there are interventions currently running that could be like this. The intervention is cheaper, but it's worse. Okay, I'm saving money, but maybe I'm, quotes unquote, killing people, so to speak. The third quadrant is whether the intervention is better. Okay, it's better, the intervention. I'm providing better, the outcome, the results, it's the patients or the citizens have a better perceived quality of life, okay? But it's more expensive, but the society is willing to pay. Or the intervention, what is called is dominant. It's cheaper and better, okay? This is the ideal scenario. The results of the MAFEIP is this curve, okay? It's a dot or a cloud of dots, and then this is the willingness to pay, where society is willing to pay. So in some cases, the intervention could be better, but it's more expensive, and the healthcare system cannot afford this. So we are in the red points here, or is more expensive, but the society or the health authorities are willing to pay, okay? Now, hold on for a second. I'm going to change the screen, and I'm going to put the online tool, okay? Wait a second.
Nel frattempo, sorry Francisco, vi dico anche a voce, il webinar è in registrazione, quindi sarà condiviso e insieme ovviamente anche le slide che provvederemo a inviarvele non appena il webinar sarà terminato o comunque nell'arco della giornata. Vi invito nuovamente a tenere microfoni e video spenti. Grazie.
Okay, can you see my screen now?
Yes, I can see it.
Okay, so if you click on mafeip.com, okay, let's start it. So from the scratch, you go to the website, you start here. Welcome to MAFEIP. Okay, here there is an explanation of the tool. You have the use cases here, so you can see how other people. This case might sound, maybe it's familiar to some of you, the Puglia case study, and CT4H has been also run by an Italian colleague, by one of your Italian colleagues, okay? Okay, so you go starting using the tool, you will be asked for a login and a password, okay? Let's use this example. This is the, if you have several examples, you will see this type of screen. You go, I'm going to go to this example, okay? The tool guides you through 5 steps, okay? Once you enter, step 1, general information. You put a name of the intervention. In this case, it's Beyond Silos. I have the approval from the user who create this case to show you this, okay? The action group, this is related to the European Commission EIP-AHA, okay? Just simple. No doubts. Settings and target population. The tool also helps you to define, okay, to define your intervention. so to speak, to support your design of the evaluation. So in any design, you have to start putting the demographic characteristic of your target group. In this case, all the population, this was the years. We have one participant was this age, both males and females. The geographic characteristics, okay, the region, healthcare service providers. What is the condition that your intervention aims to prevent? So the target population, so to speak, okay, in more concrete terms. And what are the typical disease characteristics, okay? All these elements, if you start from scratch, help you to define the sketch, input, output, and outcomes, okay? Once you finish that, they will ask you about your intervention. Your intervention relates to device, to a protocol, a treatment, others. It's flexible. Please bear in mind that this tool could be used to analyze from mobile health to integrated care, okay? So it has to be flexible enough because you never know where is the innovation taking place, okay? Then you have to brief description of the clinical implementation, brief description of the current care. Does your intervention have an impact on health and resources used compared to the current care? Please describe briefly. It helps you, again, it helps you to think about the innovation within an evaluation framework, okay? In this case, beyond silos is expected to generate savings and to improve health and social outcomes. Stage of the development is a pre-trial, clinical trial ongoing, pilot implementation, other specified. Okay? Then you go to the evidence. Here, an important remark, okay? You can use real numbers from your trial or from your intervention, okay? Or you can use estimates, okay? You can use the tool to run, let's say, ex-ante evaluation using estimates. It's just as simple as putting several cases and adding different parameters. Again, the evidence will go through several questions. Do you collect empirical evidence on the effectiveness? Yes, no. Is the study designed with evidence on effectiveness is gathered? So you go through the different questions and you start, let's say, building or capturing the evaluation you have conducted, okay? With this information is then took by the tool in some cases. So to calculate the previous slide when I was showing whether it's cheaper and better or worse and better, okay? So here it's very straightforward, okay? The number of patients in the intervention arm, numbers of patients in the control arm. Again, if you are running this in a pre-commercial ex-ante, you just put an estimate. You don't need to worry. Or if you are conducting the evaluation using the tool ex-post and you don't know because you did not capture this, just do some estimate. It's better to have, let's say, a non-optimal, suboptimal evaluation than not having anything, okay? The tool helps you to produce a preliminary estimates of the evaluation. If you have produced a perfect randomized control trial, you will capture the outcome better. If the trial was not designed as a randomized control trial, I'm sure you can estimate some of the parameters requested. After completing these 4 steps, okay, you just click here and go to model input. Step 2. Here it gets a little bit more complicated, okay? But the tool provides you with the explanations on each of the parameters we need, okay? In this case, the setup. The parameters in this section control how the analysis will be performed and how the results will be presented, okay? Some model assumptions. This is related to cost effectiveness analysis. It's called the discount factor for cost, okay? I will read it this. You will have time afterwards to go deeper, okay? is a mathematical procedure for adjusting future costs and outcomes of healthcare and social care interventions to present value, okay? Put it that way. This is that like the inflation, okay, of the model. The time horizon of the analysis, this is very important, okay? This means the number of times you want this to be, the different cycles. If you remember the first slide, we have different stages, okay, and different possibilities. Here you put a number, okay? This is because I was playing yesterday, okay? This is not correct. It should be less, okay? You put the time horizon of the analysis. So because I know that this innovation is going to be in the market for 5 years, I put 5 years. So the model will run everything during 5 years because I know that this intervention will be there for 10 years. I put 10 years. Here you put the time horizon of the intervention, okay? And then some basic information about the target population, the minimum age, the maximum, gender, the country, and the currency. This information is needed because in these transitions between stages, the tool is backed up by the World Health Organization and the European Commission data sets about gender and life expectancy in order to make these transitions, okay? To run the model during 5 years across these patients with the start, the age is this one and the maximum age is that one, okay? The traditional patient flow, so you can specify, okay, traditionally this intervention is for females starting at 64, okay? Probabilities. This is what I was explaining before. Baseline, disease, and death. Then you have the baseline. What is the incident? When the intervention, the probability to get a disease on an impairment, the probability of recovery, and here the probability of death, and moving between the different stages, okay? Again, here you will have a detailed explanation. And again, initial distribution among states, okay? So you need to put, again, if you have the figures, you put the real figures. If not, you put estimates, okay? The proportion of patients in the baseline rate, baseline stage. So I know that the population is currently, this number of individuals are here, this number of individuals are here, this number of individuals are here, okay? So you put the numbers for each individual in each of the stages, okay? And then the probabilities from moving from the control, for both, for the control group and for the intervention group. And again, incidence, you have also support, this Hoover support, incident and recovery. These probabilities are these probabilities, the probability of moving from one stage to another stage. And then the relative risk of mortality, because these models are transition models, you need to capture what is the relative risk mortality. If the intervention is for patients that are in a higher risk of mortality than the general population, okay, you just put here, okay, the probability of these people of dying is higher. So in this case, it's 0.5. The target group of this intervention, it's about integrated care. It was elderly people, 65 plus. So the having a health problem, okay, not severe, but a health problem. So the probability is higher than 1, a little bit higher. If your innovation is gonna be, I don't know, frail patients, okay, in a palliative care, so to speak, the probability will be much higher than 1, okay? This you can implement it from your trial, from your personal estimate, on even for the literature. As you may know, medicine is based on evidence-based, so to speak, and you have plenty of researchers producing figures about many, many things. So sometimes if you don't know this figure, you go to PubMed, you do a search, and I'm sure that you will find what is the relative risk of mortality for a specific condition in a specific point, okay? Cost. Two types of cost. The intervention cost and the standard cost of care or standard care cost. And then we divide it between one-off cost, meaning, for example, okay, I just have to pay one mobile per user, okay? Or recurring cost per person per year. Okay, I have to pay also the bandwidth of the person, okay? And you put the cost for the control group and the intervention group. In this case, the control group was 0, okay? Because the intervention is compared with the current situation, which is business as usual. So business as usual is not that the business as usual is the cost is 0, is that, okay, if we do nothing, we will not spend more. And then the intervention group, what is the cost for the intervention? In this case, one-off costs were the servers and all of these. Recurrent costs per year per person were the bandwidth on other type of, let's say, variable cost. And here the health state cost. Here is where you have to put healthcare costs, societal cost, and then the healthcare cost for disease impairment state and the societal cost for disease statement state, okay? Here you have the explanation for these items. And again, look, typical question. I don't know how much time my doctor or my nurse is spending on the intervention time. Okay, let's assume that the cost of the nurse is, because it's paid, I don't know the figures, let's say 2,000 euros per month. Okay, this is the cost of a full-time nurse there. He's not working full-time on the intervention, he's just working part-time. Okay, so I input 1,000 euros. So obviously in healthcare in Europe, we don't have analytical accounting, but we know the cost. More or less, we have estimates. So please don't be shy, just input an approximate cost, because you can gather an approximate cost, okay? For both, for healthcare and for societal costs, okay? Another difficult part, the utilities. So the utility, meaning the outcome of the intervention, is measured normally through quality of life, okay? Again, I don't have quality of life in my database. I didn't capture quality of life. Go to the literature and try to find an indicator that is able to capture utility. What is the impact of this? Meaning the impact of this in the individuals, okay? Not in the number of the number of time that people connect to the tool. This is not an outcome. This is an output, okay? Try to capture utility. Normally, the best way is quality of life. We start analyzing and we produce the results. We produce, I'm gonna go faster, okay? Because I would like some time for questions or doubts. Model output, it gives you this type of outputs, okay? The incremental cause and effects, okay? How? With the age, you increase the cost per person, okay? As you see, this is decreasing because people are dying too, okay? Because it's normal, I mean, it's life expectancy. And you have this also by male and by female. Then the cost effectiveness, it gives you this type of dots. It gives you whether the intervention is, here we have the incremental cost, here you have the incremental health effects in QALYs, okay? In this case, the intervention was better for the patients, okay? And more expensive, okay? However, this gives you the willingness to pay by society, the thresholds, okay? In this case was 15K per QALY. If you modify this, you see the curve moves. It was more expensive. Yes, it was more expensive, but it's worth paying for that. Okay? If the dot is here, it will mean that it's more expensive, but it's not. It's not even better. Okay? Population impact. Again, it measures the years after the start of the intervention and the incremental results used per person. Okay? And you can see how it goes, the cumulative incremental cost over the model horizon. Okay? And here it gives you also the flows, patient flow through model states. Okay? So you have in disease in permanent state intervention, the current care, in baseline state, and in current care. And it gives you the dots for each, the probability of staying in the different conditions. Okay? It's difficult to run a 40 minutes webinar on health economics. So I apologize if I'm going too fast. Okay? Last step, the tool also allows you to run a sensitivity analysis. So this sensitivity analysis means what if I change some of the parameters? Okay, what if I change the cost? So the cost is going to be cheaper, the cost is going to be more expensive, and at the end, you can modify your parameters and measure what is the result. In this case, it was measured an improvement on the quality of life. Okay, so you will get different dots. You will get two dots, the comparison and how changing one parameter affects to this. Okay, this is why this tool can be used with healthcare costs and also with societal costs. Okay, this is why this could be used for planning. If I expect an impact of this or an impact of that, and you play with the scenarios, okay? You play where are the different dots, okay? Okay, that's a really quick overview of the tool, okay? Let me switch back to the present. Well, I will keep this, okay? Just in case there are specific questions, okay? We are here to support you. The European Commission is running two projects, where MAFEIP and Digital Health Europe. And this is with these two projects, we are supporting different stakeholders across Europe to use the tool, run evaluations in their innovation. I stop now. Thanks a lot for your patience. And again, apologize if running a health economic course in 30 minutes was not good enough. Thanks a lot.
Thanks, Francisco. Thanks for your overarching presentation. Let me speak now in Italian for the audience. Intanto grazie a tutti per aver partecipato. Partiremo da alcune domande qui nella chat. Volevo solo ricordare dare alcune informazioni su questo percorso. Appunto, come già detto prima, dovevamo fare un workshop completo, ma appunto per i problemi del Covid abbiamo affrontato la decisione di spezzettare l'attività e di dare comunque avvio a un'attività relativamente in ambito EIP-AHA, comunque fin da ora, che parte da una serie di webinar, quindi da questo e per i prossimi, anche per le prossime settimane vi daremo sicuramente ulteriori informazioni in merito, ma che sicuramente al termine di questo periodo ripartirà anche con delle attività vis-à-vis, quindi come si suol dire, stay tuned relativamente all'attività del Promise nell'ambito dell'invecchiamento attivo. Come detto prima durante la presentazione, le slide, la registrazione vi sarà inviato, saranno fornite tutte le informazioni insieme anche a una sintesi di quanto detto dal relatore, appunto le parti essenziali. Ora ripartiamo da queste prime domande, perciò Elena, se tu le hai raccolte e vuoi leggerle già in inglese, alcune sono arrivate, e comunque vi chiediamo di scriverle se possibile, così evitiamo di attivare microfoni e quant'altro, e permetterci a noi organizzatori un'attività più agevole e di gestione del webinar. Grazie a tutti. Elena, se vuoi.
Ok, sì. Ok, so the first question is not a proper question. Is I did not understand clearly how to put proportion of people in a different stage.
Okay. So when you are running the innovation, an innovation, okay, you are running this innovation in a target group, okay? This target group, you should know them. So you should know them a little bit at least. How many of them are in a let's say in a condition A? So they have a specific level of a specific of something. How many of them are in a condition B? And how many of them are in a condition 3? So you assign patients to the different groups depending on how you define each of the states, okay? Imagine the states is about frailty. This group is in a scale of frailty in group 5. So the baseline is we are targeting individuals in a frailty scale from 5 to 7. The baseline will be 5. The disease impairment will be 6, okay, and the other one will be 7. So you assign patients to the different status depending on your population. I don't know if it's clearer now.
Ok, se avete trovato la spiegazione chiara, magari se ci date una breve risposta nella chat, così possiamo passare alla domanda successiva. So, sorry, I will speak Italian too.
Yeah, please go in Italian. I think I can understand.
Okay, perfect. So we can go with the second question, which is it possible to use the tool also to estimate how much an intervention must cost in order to be cost efficient?
Yes, a very good question. Yes.
So just let me, okay, yeah, sorry, move forward.
Yes, you can you can do this in 2 different ways. First, you run the model till the end, okay, and then in the sensitivity analysis, you start playing with different costs to see how the dot moves up and down. So then you will see what is the appropriate cost to achieve the appropriate outcome. Okay, so the tool allows you to play with the estimates and to see where is the optimal situation, so to speak.
Okay, so in relation to the question, to the first question, it seems to be very clear, but into the tools, how we can put, the question is how we can put this proportion. And another question, sorry, is what kind of support you can give in case someone wants to try to apply the tool?
Okay, the first question, if you go to the model inputs, you see here the probabilities. Here is where you play with the transition probabilities, and here is where you put the proportion of patients, okay? And here is where you put all the information related to the probabilities is in the second step, model inputs, okay? Second question about the support. As in the healthcare system, resources are limited to for this project. What is the type of support we provide? Okay, you send an email to info@mafeip.eu, you become a member of the community, and then what we do is we try to guide you through the tool and through your intervention through, let's say, Skype, okay? So we try to set up meetings and we give you support on how you can do this or how you can do that, okay? Also, what we are trying also to do is, you see your you have in Italy colleagues that have run this tool, has used the tool, the Puglia case, the CT4H case, okay? We are trying to also to have other members of the community helping people around, okay? So first thing, send us an email, become a member of the community, set up a meeting, and then we start helping you, supporting in the use of the tool.
Sorry, Francisco, can you please write down the address you mentioned on the chat and finish the presentation, like the question time. So the last question for now is, how can healthcare organizations that have developed or tested solution measures, measure the impact despite not having measured the parameters indicated by the tool?
This is a good question too. Okay, the point is, you can do estimates. If you don't have these parameters, I mean, let's estimate that the tool used the best available information. If I don't have this information because I didn't capture this in the trial, my suggestion, go to the literature, try to find other study, similar study that gives you these figures, and then adapt this figure to your context, okay? The other thing is, there is a lot of systematic reviews and meta reviews in the healthcare domain. Just use them. Go there, check a systematic review, and see what parameters have been used, what are the values, and then adapt this, shape these values to your reality.
Okay, so we don't see more questions, so please a tutti i relatori, scusate, a tutti i partecipanti, se ci sono ulteriori domande, per favore scrivetele nella chat, così le possiamo comunicare al relatore.
Grazie Elena, Francisco. Sembra che non ci siano più domande. So, Francisco, thank you very much. Thank you all. We invite all participants to send you an email in case of need. Ripeto, slide e registrazione saranno a disposizione di tutti. Ringraziamo nuovamente il relatore, vi diamo appuntamento, quindi vi lasciamo mezz'ora grazie per aver indicato anche il tuo contatto email, vi lasciamo mezz'ora per una breve pausa, caffè, insomma, le vostre attività, e poi riprenderemo sempre su questo link anche appuntamento. Quindi grazie a tutti, thanks Francisco, alla prossima, grazie.
Grazie.
Thanks.
Grazie.
Il microfono spento.